Play.
Hello, Shagun, can you hear me? Shagun, can you hear me? Hello, am I audible?
Yes, sir. Morning, sir.
Morning, Tanu. All others are joining. Shagun, can you hear me?
Yes, sir. Audible, sir.
All
You're
right.
audible and visible clearly, sir.
So you can allow her to share the screen. I think let people join. Give a break of 5 minutes.
Okay, sir.
Shagun, let everybody join. We're giving them 5 minutes.
Yes, sir.
I think we can start. They can keep joining because, or should we wait? Yeah, Tanushri's screen is visible. I think they're still entering. So I think we should start because we'll get late otherwise. Dr. Tanushri, are you ready? You've shared your screen. So, good morning,
Yes, I'm
everyone.
ready.
We're starting with the very regular Sunday Gurukul Zoom classes, which we used to do last year. We started in the COVID times, and we were very happy that they were very much liked and appreciated by a lot of students. Uh, and we would make sure that we have them on a regular basis and do feel free to register and present your cases. So I think while people are joining Shagun, they can be allowed to enter and we can start. So
Yes,
we
sir.
are having one first case being presented by Dr. Tanushri Nahata. She's a third year postgraduate. So makes sense to have a presentation by third years where second years, first years can also chip in, and we'll make that into the entire final year exam being covered in the next few days so that all those who are appearing for their exams can find it useful. Let's start with you, Dr. Tanushri, please.
Thank you so much, sir, for the opportunity. Good morning, everyone. I'm Dr. Tanushri Nahata, and I'll be presenting a case of an abdominal lump. So, a 73-year lady, Hindu by religion, literate, and a homemaker, resident of Delhi, she presented with chief complaints of generalized weakness for 4 months, melena for 2 months, and pain abdomen for 2 months. So she was apparently all right 4 months back when she complained of generalized weakness for 4 months, which was insidious in onset. She also complained of melena for 2 months, which was insidious in onset. and she noticed a gradual change in color of the stools, the color becoming darker and tarry, semi-solid in consistency. Quantity of the stools remained more or less constant and difficult to wash away, associated with intermittent episodes of pain abdomen. She also complains of pain abdomen for 2 months, which was insidious in onset, gradually progressive, dull aching, intermittent, more in the right upper and the middle abdomen, non radiating, with no aggravating factors, and was relieved by oral medications. There is no history of any constitutional symptoms like fever. There is no history of any vomiting or hematemesis, and there is no history of jaundice, no history of any back pain. She is a known case of ulcerative colitis since 2005, and she is on 5-amino salicylic acid tablets. Montreal classification is E3. She's also a known case of diabetes mellitus type 2 for 30 years, and she's on OHA. There is no history of any hypertension or asthma. Talking about the past history, she had invasive breast cancer of the left side in 1989, for which she underwent modified radical mastectomy, and she received chemotherapy, tamoxifen, for 5 years. Her so the ER status was ER positive, PR positive, HER2 negative. She also had pulmonary tuberculosis in 2000, and she took ATT for 1 year. She also underwent bilateral salpingo-oophorectomy and hysterectomy in 1995 for query menorrhagia. There is no history of any HNPCC or any other syndromic history in the recallable family members, and there is no history of any untimely death. Talking about her personal history, her appetite has gradually reduced to half of what was 4 months back. She has a history of 4 kg weight loss in the past 4 months. From 84 kg, she's gone to 80 kg. She's a vegetarian. Her bladder habit is normal, and there is no alcohol or tobacco consumption. She attained menarche in 14 years of age, regular cycles, normal flow initially, followed by menorrhagia, for which she underwent hysterectomy and bilateral salpingo-oophorectomy, and hence she attained menopause 29 years back. She's married, has 3 children, all were full-term normal vaginal delivery, and they were breastfed for 2 years each. So summarizing my case, a 73-year lady with complaints of generalized weakness for 4 months, which was insidious in onset, melena for 2 months, which was insidious in onset, black, tarry, difficult to wash away, associated with intermittent episodes of pain in the right upper and middle abdomen, which was for 2 months, insidious in onset, gradually progressive, dull aching, intermittent, relieved on medication. She's a known case of ulcerative colitis, E3 Montreal classification on treatment, and diabetes mellitus type 2 on medication, with a past history of invasive carcinoma breast left side, status post MRM, and tamoxifen intake for 5 years, pulmonary TB, status post ATT for 1 year, bilateral salpingo-oophorectomy and hysterectomy for query menorrhagia, with reduced appetite and insignificant weight loss.
Right. So, if we can analyze your history a little bit, that will help. Now,
Yes, sir.
what do you take home from your history?
Sir, most likely she has a carcinoma of the right
No, that's
colon.
okay. That's okay. But you put in too many other comorbidities alongside, including what she was getting treated for, and the ulcerative colitis, as you mentioned, and also the previous surgery for breast cancer and the tamoxifen that she's been on. Could you connect the dots somewhere?
Yes, sir, it could very well be a syndromic presentation like Lynch syndrome. And also, if not syndromic, then ulcerative colitis patients, they are prone to have carcinoma of the colon later. So it could be a manifestation of that as well.
Excellent. So we'll start with your first slide so that we can make the history ready for the exam. Now, this is perfectly done. In fact, you did it quite well. I must compliment you for that. But the important thing is when you're mentioning the the chief complaints are fine. Can you move to the next slide, please? Yes. Uh, is that the first complaint, generalized weakness?
No, sir. The first complaint was actually black stools and pain abdomen, and then she
So,
told
so
about
why I
generalized
was
weakness.
asking you this was, although this could be right, because sometimes they may just have generalized weakness or asthenia or loss of appetite, etc., as the first symptom. But then she did not mention that as the first symptom, according to you, because her, if you look at it, generalized weakness 4 months, and Melina is 2 months. So did she start that way, or when she was saying? Because now what has taken precedence over her usual, history, which you would recall that she had, is Melina. So she's forgotten about those 2 months when she was having a generalized weakness. But it's important. Sometimes it may just start as a unexplained fatigue, right? So important, and especially in a cancer patient, previously treated cancer patient, or a patient on some kind of a therapy for inflammatory bowel disease. Let's call it that way, because it's no longer just the colon, because it may involve the small gut, and the Crohn's may involve the large gut also. So therefore, we can use it inflammatory bowel disease. And she recalled probably about the generalized weakness, but essentially it was melena for 2 months, right? Am I right?
Yes, sir. Yes, sir.
Yeah. Now, semi-solid, this was very well explained. In fact, that's how most people should, making it very clearly visible to the examiner that I'm talking about melena, not just black stools. So how are the two different, Tanushri?
So Malina is tarry, and it is difficult to wash away. It has an offensive odor as well, and the consistency is semi-solid, so can be liquid as well.
All right, and just the black stool is not melena. That's what was the important point I wanted to highlight. Now, it could be related to, the black stool could be related to some therapy, or say iron tablets, or the kind of diet the patient is taking, etc., etc. Okay, so next slide. Now, you mentioned intermittent pain in abdomen there in the previous slide already. Now he says she again complains of pain in abdomen for 2 months. Are you getting what I'm saying? Because either you connect it there only,
Okay.
or you mention it separately, so it'll um, make it more emphatic. I don't have a problem with that, but generally sounds better.
Okay, sir.
Now you explained the pain abdomen very clearly. What kind of a pain do you think it is?
So this is a colicky pain in the right side of the
Wonderful. So you
abdomen.
should have said she also complains of colicky pain abdomen of 2 months duration, which has been insidious in onset, progressively increasing, and now is taking dull aching. Now, how could it be both?
Yes, sir.
Which has progressed to being a dull ache now, because it can happen. Initially, it was obstructive, then it became, infiltrative, that kind of a pain. So, more in the right upper quadrant, middle abdomen. So, put them in the right perspective. This is like, making your history even better. And relieved by oral medication, which means what?
So antispasmodics and analgesics
So,
over
when you
over the
say
counter.
when you say antispasmodics, what is it that you are implying? It is a colicky pain,
Colicky pain.
because only colicky pain would respond to antispasmodics, because colic is caused by excessive parasympathetic activity, and all these drugs that you're talking about are anti-parasympathetic only, parasympathetic drugs that you use for taking care of colic. Other pain killing medicines are general analgesics, which work at the what do you call, the root of the pain, the way it is carried, and the whole arc of it. Correct. Let's move. She complains of pain of abdomen 2 months intermittently. This I think you covered. Next.
Yeah.
Now, when you're saying no history, see, we are interested in this very much. Now, this is useful. No history of any constitutional symptoms, no history of vomiting, no history of jaundice, no history of pain. Now, Tanushri, define what is a colicky pain. What are the characteristics?
The colicky pain is the pain that a patient feels in the abdominal region. It comes and goes off. It's like a intermittent pain, and it is of a dull nature, and it can radiate to other parts as well, like
Is
back.
it associated with vomiting or not?
Not always.
All right. Now, why does colicky pain happen? See, colicky pain happens due to block in any tube. And why block in any tube? Because the tube is blocked, the proximal part of the tube tries to overcome by excessive activity, right? By excessive contraction. So there is more likelihood of it is coming in waves, no? And on pressure, it is relieved, and on using antispasmodics, it is relieved, and it is usually associated with vomiting. The vomiting is not caused by reverse peristalsis, but by pylospasm because of the vagal stimulation. This is a vagal pain. Colicky pain is a vagal pain, as you also said. So if it is a vagal pain, then there will be pylospasm also, because pylorus is supplied by the
Because
branch from the hepatic branch of the anterior vagus, right? Anterior division. The main trunk divides into. I'll try to draw that when I get to use my whiteboard. But that was the point, which is so when you say no history of vomiting, better be sure either way that the colicky pain is there or not. And it doesn't have to be a colicky pain of the upper GIT to cause vomiting. Please understand. Even ureteric colic produces vomiting. Even dysmenorrhea may produce vomiting. I mean, the obstruction of any tube that is getting blocked can produce vomiting because of the parasympathetic overactivity. And when I'm saying parasympathetic overactivity, remind me when I'm talking about your case, I'll try to explain as to how vagus works to make it happen. No history of jaundice, no history of back pain. Okay, let's go. Now this becomes important. So now when I was listening to your story, it is not a bad idea to introduce this ulcerative colitis concept in the very beginning of your history, so that we are already preoccupied, I mean, a kind of conditioned into thinking that it is going to be, it's a kind of a colicky, I mean, kind of a colonic problem in the background of um, ulcerative colitis.
inflammatory bowel
So
disease.
inflammatory bowel disease. So we start thinking automatically that way. So, well, what I would have done was I would have gone back to the beginning and would have mentioned this so and so lady on a treatment for ulcerative inflammatory bowel disease since 2005. So the history goes back to her ulcerative colitis rather than it becoming a past, because it is in continuation that we are discussing it now. So this would be a colonic pathology developing in the, in the background of inflammatory bowel disease. So makes sense to us. We connect the dots faster that way. So I'm just trying
Okay.
to, make you understand how do you make it more emphatic. Now this diabetic thing is okay. That can come out anytime. But past history of breast cancer is also fine, which you describe very well. But but this one, you since you're putting it as a known case, so this was to begin with a known case, so you can start with that. What that would do is you'll get a continuity of inflammatory bowel disease culminating into something which you suspect is not a good news. So we can connect the dots better. Okay,
Okay,
I wanted
okay,
to
sir.
come to this point for this purpose. Now let's talk about patient is on ASAs. Now, when the patient is on ASAs, what can be its implication in your patient?
Sir, I don't know, sir.
The kind of this therapy is also known to be, is what kind of a therapy is it? Is it immunosuppressive?
So I'm not aware of this.
What is the therapy for inflammatory bowel disease? Mostly immunosuppressive, and it has a negative impact. It increases the risk of, no, although it is believed that this therapy for ulcerative colitis reduces the risk of colonic cancer, I'm saying in a different sense. But all immunosuppressive therapies can predispose to cancers being developed. But
Yeah.
here we are talking in a different context. It is believed that if you have a patient who is on treatment for ulcerative colitis, and if the ulcerative colitis is an early disease, then they don't change into malignancy that commonly. So it's important. And what do you mean by Montreal classification of E3?
So Montreal classification has two types. One decides based on the the stools and the bleeding, and one is based on the severity of ulcerative colitis. So this is E3, sir.
Very good. And how does it help you make any impact?
So this is the severe type of ulcerative colitis, and
Sorry, something happened?
hello.
Are we okay?
Yes, sir.
Huh. Can you repeat that, please? Sorry, I didn't hear that.
Sir, this is a severe type of ulcerative colitis.
Yes. So how does it connect with the probability of developing cancer? That's what I'm asking. No? Risk.
Sir, I don't remember the percentage, but this has the highest conversion of carcinoma in probably 8 years.
That's a good answer. But importantly, the severity is linked to the chances of developing cancer. So that's what I was asking. So more severe, untreated, etc. And therefore, the treatment is supposed to reduce the risk. Important to know. How would it be relevant in our case? We'll talk later. No history of hypertension or bronchial asthma. That's right. Next slide.
Yes.
It is important. How is the 5-year tamoxifen going to be relevant in this patient?
So normally in premenopausal women, tamoxifen is relevant because we have to do regularly pap smear. They are at a higher risk of endometrial carcinoma. But in this patient, already she has undergone a hysterectomy, so not that
No, but
relevant.
this is just one aspect of it. No, developing in the cancer of the ovary, that's okay. Uh, or sorry, of the uterus, which is okay, which is one thing you look at. And like you said, it's a syndromic patient, so we could look at other cancers that can develop. And tamoxifen does protect in general from the other cancers also, which are hormone dependent, estrogen dependent, that is primarily. Although it's a modulator only. But it's important to highlight these points. No? That's why I was asking. Now, any menorrhagia you mentioned?
So she had menorrhagia prior to her surgery. The documents were not availed of exactly what was the cause of menorrhagia, but she is
What would you suspect if you were the treating doctor?
so
Patient
most
is,
likely fibroids.
but she has no uterus, no? This is before breast surgery. She underwent
Yes, sir.
she underwent surgery for this, but we need to really trace it back to whether it was malignancy or not, because that also would help us confirm that it is a syndromic case.
Yes, sir.
Okay, let's go. Now that's a brilliantly taken history. And when you say HNPCC, what are the cancers you're including?
So Lynch syndrome or Moore-Torre syndrome, and other polyp cancers. If I'm talking about that, could be FAP, juvenile polyposis.
And in Moetore, how is it linked? Moetore would be sebaceous gland malignancies with visceral malignancies, no? So is it connected here, Moetore?
No, sir.
No history of untimely death in the family. Okay, let's go. I think this is significant, and you mentioned it. Do you think the weight loss is very significant?
No, sir. It is not 10% of her initial body weight.
Right. And therefore, when you mentioned initially that she was generally feeling fatigued and exhausted, we need to qualify that further because it becomes important for us. No alcohol or tobacco consumption. Very nicely taken history, personal history. Let's move. I think this is adequately done, so I would not take a lot of time here. Um, and we have a patient who's probably optimally, she's not looking high risk from that angle, so we are good. Let's go. In the summary, you brought out very nicely, and actually, that's why if you were to look at uh, you know the the generalized weakness in this insidious onset. So this 73-year lady on treatment for inflammatory bowel disease for the last 8 years, 10 years, started complaining of generalized weakness for 4 months duration, associated with melena of 2 months duration, which was insidious. And we don't have to repeat, wash away, etc., because that is how it is melena. and gradually progress to dull aching pain in the abdomen, and rest gets covered automatically. Okay, so it becomes
Okay, sir.
more contextual. Let's proceed to examination.
Okay. So I examined the patient in a well-lit and well-ventilated room after taking appropriate consent. I exposed her abdomen, her genitalia, also her thorax, and her bilateral axilla. So her Karnofsky score was 80 and her ECOG score was 1. She was averagely built and there was the presence of anemia. Her pulse was 90 per minute, regular with normal flow and volume. Blood pressure was 118 by 84 in the supine position taken on the left arm. And she was on room air, afebrile. Pallor was present. She was dehydrated. There was no pedal edema or icterus or cyanosis, and there was no generalized lymphadenopathy. Talking about her abdominal examination, on inspection, the abdomen was non-distended. However, there was fullness seen in the right hypochondriac and the right lumbar region. The umbilicus is midline and it is shifted downwards. The flanks are not full. The scar of the previous surgery, there is a lower horizontal midline scar, which is the phalansteal incision, and it is healthy and it is healed by primary intention. There is no dilated veins on the abdomen, no visible peristalsis or pulsations, and the hernia sites are normal. The back is also normal. On palpation, the abdomen is soft, it is non-tender. There is an intra-abdominal, intraperitoneal lump in the right hypochondriac and the right lumbar region of approximate size 6 by 5 centimeters, which is of irregular shape and smooth in surface. It is non-indentable. The consistency is firm to hard. The margins are well defined, other than the superior margin, where fingers cannot be insinuated above the lump and below the costal margin. It is a bimanually palpable lump and a non-palatable lump, and there is no other abdominal lump. I would just like to share a video. So this was the lump out here. I could feel the margins being regular and well defined.
Anushri, we can't see the video.
Okay.
Maybe have you got it in the slide itself, or
No, it's not in the slide. It's somewhere. It's on other place.
maybe once you finish your presentation, you can share the video also. We
All
can
right.
describe the finding. Otherwise, you'll have to probably go out and again share the screen. Something has to be done more than that. I mean, I don't know whether you can show the video straight away. Yeah,
Okay. So I'll continue with my examination. There
please.
is no splenomegaly. On percussion, the liver span was 12 centimeters in the right midclavicular line, starting from the fifth intercostal space, and there was no free fluid in the abdomen. On auscultation, bowel sounds were present. On digital rectal examination, the anal tone was normal. There was no growth or blummer shelf, and the gloves were fecal stain with black tarry and sticky stools. After changing my gloves, I also did a PV. A vault was examined, which was normal, and there was no pelvic deposits felt. On general examination, I found that the left Virchow's lymph nodes were also palpable. Systemic examination was grossly normal, and the MRM scar was also healthy. The right breast was normal, and the bilateral axilla, there was no palpable lymph nodes. The spine also had normal curvature and no tenderness. So talking about my examination point, on examination, she was found to be anemic, dehydrated, with a Karnofsky score of 80, ECOG 1, and was having an intra-abdominal intraperitoneal mass in the right hypochondrium and the right lumbar region, which presented as fullness in the same regions on inspection, with umbilicus shifted downwards, and on palpation, it was firm to hard, irregular mass of size 6 by 5 centimeter, with smooth surface, well-defined margins on all sides, except on the superior side where the fingers could not be insinuated between the mass and the costal margin. The liver span was 12 centimeter, with no hepatosplenomegaly. DRE showed black tarry sticky stools with a palpable Virchow's lymph node.
Right here, you mentioned palpable Virchow's lymph node, and in your presentation, you mentioned left Virchow's lymph node. So there's no right Virchow's node.
Yes, sir.
There's only one node which is called Virchow's node. By the way, what is that node?
So basically, it is a scalene group of nodes on the left side, which is located between the two heads of the sternocleidomastoid muscle.
And you feel it against the scalenus muscle. So, scalenus anticus. So, it is a scalene node, not a left supraclavicular node as they commonly mention. So, your examination, can you go back? Do you want to play your video?
Try so if they can,
So, you'll
it
have
can be
to
seen.
stop sharing your screen and then share again with the video. You
Okay.
open up your video.
Yeah. So is it visible now?
I think just about play it. You can describe. Yes, we can see it now.
Okay. So this is a very small video. This is the lump, and the margins I could actually feel very nicely. I'll also show how my fingers were not able to insinuate between the lump and the costal margin. So this side I could, but this side I couldn't. Yeah, that's it.
Now we can keep that clear. Like when you're examining it, needless to say, you need to examine from the normal side and you get to the abnormal side. So let's take your journal examination, which is perfect. I think you can't make it better than that. So I would not mess with it. So when you say generalized lymphadenopathy, for the benefit of everybody who's here, what is it?
So it has to be enlargement of lymph nodes in at least 2 or more groups of the lymph nodes in the body,
Non-contiguous groups.
non-contiguous.
And when you say nourishment, anemic, so I think you will go poorly nourished on account of anemia, right?
Yes, sir.
Yeah. And although her BMI may be all right,
Yes, sir.
because I remember this patient, I've operated on this patient. So BMI is all right. So we are looking at um, uh, we are looking at a patient with anemia who's got a little dehydration, but there is nothing else that is positive. And Karnofsky 80 is also very tight because she's not that fit. 80 is not too bad actually, but
Mm.
maybe somewhere between 70 and 80. But ECOG 1 is more easy to understand. She's border between ECOG 1 and ECOG 2. Can you tell us
Mm.
about the ECOG staging?
Yes, sir. So ECOG is Eastern Cooperative Oncology Group for Cancers, and ECOG 0 is when a patient can carry her normal day-to-day activities as well as strenuous exercises. ECOG 1 is the normal activities she can do, but he or she can do, but the strenuous activities they cannot do. ECOG 2 is when this self-care is taken. The patient can do self-care nicely, but the normal activities the patient cannot do that much. ECOG 3 is when the patient needs help in self-care. ECOG 4 is uh, so able not able to do self-care, and ECOG 5 is death.
There's a question by Asif in journal physical examination. Can we just say that her vitals are essentially normal and just point out positive findings? This is what she has actually done. I think there's a very limited scope to escape in a cancer patient, Asif. Performance status, nutritional status, and hydration status. So if we don't cover that, we'll be missing out. Now we won't be too much bothered about SpO2 or other things, but this she did not take a lot of time. You see, generally to skip it is mainly to save on time. But if you're making sense, nobody really gets bothered on how long did you take. It's not a good point to, not a good idea to go slowly describing all these features. So if you can quickly wrap it through, that's no problem. She hasn't wasted a lot of time there, so that's why we did not have a problem. But yes, positive findings can be mentioned, and some are important, like no generalized lymphadenopathy is important for us. No pedal is important for us because she's assessing the patient nutritionally. Dehydration is present, anemia is present. So therefore, a lot of findings are quite relevant in this patient. That's why she probably mentioned. But I take your point. If you don't have, I mean, like in a patient where you don't expect too much of a disturbance, there's no point, going on till the cows come home because that is not what we need to be doing. Let's move to your next slide. Do ask questions, all of you. Most welcome to ask questions. Don't worry about it. It's a class, and if there is somebody sitting in his room and sleeping, believing that the recording would take care of it, it's not true. Please attend live and ask questions live. Go back with your answers. This was excellent, and you did it very well. Although we will take your class on physical examination as well when we do our scrubs course, we will teach as to how you should examine. What was the significance of not being able to get under the of being able to get under the costal margin or not able to get under the costal margin?
Sir, the lump could be either adhered to the liver or it could be involving the liver as well. And either it could be a hepatic mass which was getting infiltrating the colon. So that
So
was it.
in your case, it was a lump. It was a lump that was moving on respiration, and you could not get above it. Am I right?
Yes, sir.
So would that would mean it's continuous with the liver, and therefore the liver dullness continuity has to be also mentioned in the same breath. Don't wait for percussion section to come through. Next slide, because we don't want to waste time thinking. Now, when you're mentioning that you could not get above this, and you think there is continuity with the liver dullness, then it becomes relevant to mention the liver dullness in the same breath. And
Okay.
mentioning that, because naturally when you say it is continuous with liver dullness, then you're trying to let us know either it is arising from liver or from a part of the bowel which gets stuck to liver, or anything else, or any lump which is, in continuity with liver. So it becomes easy to understand. So ambiguity is taken care of. So non-tender intra-abdominal intraperitoneal lump. So, and when you say intraperitoneal, can it be extra-abdominal?
No, sir.
So it's like, um, it's an intraperitoneal lump which is in the right hypochondrium and is extending onto the right lumbar region. Perfectly fine, 6 into 5 centimeters. Surface is irregular, smooth, non-indentable. Now, smooth, what is smooth?
So non-bosselated.
No, you mentioned surface is irregular. Then what is smooth here?
Uh, so the
Uh,
shape was irregular.
avoidable,
So
no?
okay,
Avoidable. Because
okay.
what you're trying to say is I could distinctly palpate it, but that is not smooth. This is smooth in your usual talking, but here smooth would mean either the surface or what else? There's nothing else. Firm to hard in consistency, margins well defined except the superior margin. Fingers cannot be insulated, and that's perfectly fine. Now, bimanually palpable. Now, you got to be careful here. How do you do bimanual palpation?
So in bimanual palpation, the patient is slightly
Where is your
tilted.
left hand in bimanual palpation in this case?
So behind the abdomen on
Where?
the back in the right
Where?
flank.
Where?
Um, Sir, exactly below the lump.
So, when you talk about this window, in the backside, there is only one window, which is the renal angle.
Yes, sir.
And you ballot only to rule out a kidney or bimanually palpable. Very large lumps can go so far backwards that you don't really have the space is also filled. Now, bimanual palpation is a very dicey, very dicey term, because very often we tend to believe that bimanual means one hand behind, one hand in front, and we are done. That's not it. This hand could be on a muscle. This hand could be on a bone. There is very little space. You'd be very
Hmm.
surprised. The space there is almost negligible. And the only window we have there is renal angle. So we put it there and then the anterior part. If the lump is too large, then everything gets widened. So that is a different story. So biminally palpable, non-ballotable. What do you mean by that?
So that I could feel it, but if I pushed it from
There,
behind, I
there is
couldn't feel
a
it
there
anteriorly.
is a video of mine describing it. The term ballotment came into being with the obstetrics story. You all remember that fetal ballotment.
Yes, sir.
When the fetus is in the ocean of water, you push from one side, it is not reaching the other side. So you push it so that it goes floating. I can't see myself, so my hands are visible.
Yes, sir.
Okay. So you push it from here. I'll take the example of something which is close to me, around somewhere. So I carry this. Now, if I can feel both sides, are my hands visible, Anushri,
So
Tanushri?
slightly above, if you could do. Slightly to get. Yes, sir. Perfect.
Now, I am hold. This is a lump which is not looking like one, but I'm sorry for that. I'll just try to make it relevant. Bimanually palpable. Any confusion?
No, sir.
Right. But if it is very little, I push it, it touches, and then goes back. That is ballotable. So what is bimanually palpable cannot be ballotable.
Yes, sir. Okay. Got it.
Is it clear now? Because
Yes,
this
sir.
this confusion is very very common in students. People speak it in one breath without knowing what it is. I mean, if you can touch both sides, you don't need to ballot it. Bimanually palpable. The fetus is not palpable on both the sides, so we used to do fetal ballotment, and that was done for kidney also. And ballotment is only possible for a lump which has got um, a pedicle, unless it has to be mobile to be going. So ballotment is not possible if it is not able to float. So bimanually palpable, and you don't need to mention non-ballotable. It's common sense because if you are bimanually palpable, you won't be ballotable. Correct?
Okay.
Next slide.
Yes, sir.
This is not a coaching class, so you're learning what is clinical, and more that is missing because that people get away by this and then they'll start discussing the theory of it, which is not going to make a lot of sense. So you should. I'll try to cover up the examination in between. I'll try to stuff in some videos of examination that you can record also when I'm doing it in the clinics. You can come and record, and that you can share with the students so they would know. No splenomegaly. Did you specifically look for it? If you said no organomegaly, would that take care, or you wanted to talk about spleen specially?
No, organomegaly would have been better.
Well, I am happy either way if you have justified it. I mean, and you have something specific in your mind which can cause splenomegaly. That is okay. Percussion you mentioned here. See, I would like to hear about its continuity with this lump.
Sir, on percussion, the dull note was in continuity, sir, with the
Now, I
lump.
would like to hear it here, or I'll like to take it there because this continuity explains the continuity that you're referring to. So, palpation, you could not get above the lump, and you found that it is continuous. But on percussion, you confirm that it is continuous. So, that is the difference. Are you getting, Tanushri, what I'm saying?
Yes, sir. Yes,
So,
sir.
in one breath, either there or here, and don't wait for this percussion, message to arrive before you start talking about percussion. It would have made sense there itself when you're talking about continuity with the liver dullness, about continuity with lump. Couldn't get above with the lump, so it's continuous with liver. But on percussion, it, again explains it. Auscultation bowel sounds are present. DRE normal, anal tone, no growth of blummer shell, gloves, fecal stain, black tarry, sticky. Excellent description there. And the work cause node, of course, is sorted. What is the reason for this node getting enlarged?
Sir, it is because,
Excuse me.
sir, in abdominal cancers, particularly, these cancer cells, they pass from the lymph nodes, from the lymphatics to the thoracic duct, and the opening of the thoracic duct in the brachiocephalic, because of the close proximity of the left-sided subclavian veins, there is a back pressure, and because of this, the metastatic cells are going back to the lymph nodes which are in
Okay,
the
okay, okay,
scalenate
okay,
lobe.
okay. So I'll remind me when I use I don't know if I use the whiteboard, you shouldn't disappear. That's why I'm worried. I don't want to fiddle with it right now, but when I do it, you remind me. I'll show you. Actually, see, the whole idea is thoracic duct opens at the junction of IJV and the brachiocephalic. And let's talk of the left side. And separately, the scalene nodes drain at the same point, but separately. So if by permeation the metastases are going along the lymphatics and they go and block the junction, then there's a reflux back of lymph. So this node may not be hard as a classical, metastatic lymph node. It may be just ballooned. Are you getting what I'm saying?
Yes, sir.
I'll describe that and you will remind me. We just have it, getting filled with the back pressure, indicative of a systemic disease, because the moment you mention this, if I have to ask you the stage, it becomes a stage 4 disease. I would not even go there. But then you need to prove that it is a metastatic lymph node. Very, very important. This is aptly done. Let's move. Now here probably you could have, you've not missed out anything. And my friend was asking earlier about, making it um, a journal, a concept, or describing everything here is important for me, which is taken care of right breast. In fact, I would rather consider this as a distinction slide where you are mentioned the bilateral axilla, you mentioned the entire concept of metastasis and the residual disease, because that's a very smart way to get over with it. It's possible that in a breast cancer patient, so many years after treatment, there is a metastasis to the liver and that is manifesting as a lump there. I'm not saying this is the case, but this is how it becomes important. And I'm glad she didn't waste a lot of time on CVS and respiratory system, but in this patient, it will be important to highlight the important positive points. Let's move. The summary is done. Let's move to your differential. Now, before I move, give us your differential, then I'll ask people to put in their questions. Yes?
So most likely my differential diagnosis, firstly, it would be a carcinoma of the right colon.
Tanushri, how do you give a diagnosis is important in any patient? Do you have a slide after this or this is your last
No,
slide? Okay.
this is my last slide.
Okay.
So a 73-year lady with a mass in the right upper abdomen, most likely carcinoma of the right colon.
Well, if I was Tanushri, what would I do? A 73-year lady on treatment for inflammatory bowel disease. You getting what I'm saying? Am I audible?
Yes, sir. Yes,
Okay.
sir. Yes, sir.
Inflammatory bowel disease with a lump in the right hypochondrium. Now, there's no upper abdomen. You've already examined and you've said it is hypochondrium with extension to the lumbar region, likely to be malignant, probably carcinoma of the colon involving the hepatic flexure in the background of inflammatory bowel disease. With a clinical stage,
T4, and
CT4, I would not comment on
CT4,
N, and I'll have a doubt of M1, which is because there is a Burkhouse node
supraclavicular
palpable.
limb. Yes.
And that would complete your differential. Any questions from anyone? There's one which I can see. Meanwhile, you can ask questions before I proceed. Any questions, Shagun?
Yes, sir. Sir, is there any protocol about screening? I mean, I don't know if this is the right time. I mean, I had this question. If this is the right time to ask, like, is there a protocol for screening such patients? Like, the screening different from regular patients and the patients with inflammatory bowel disease for colon cancer, sir?
Tanushri, you would like to answer or I answer that?
Yes, sir. So in patients with ulcerative colitis, after 8 years of the onset,
Yes,
we should
Tanushri.
start the colonoscopy. Am I audible?
Shagun,
Yes, sir.
am I
Yes, sir. Yes,
audible?
sir. Audible, audible. Yes, sir.
Yes. So,
Hello?
in patient, hello,
Am I
am I
audible?
audible?
Yes, sir. Both are audible, sir.
Yeah,
Okay.
so she froze in my frame. I didn't hear the answer. Tanushri,
So,
can you?
in
Yeah,
patients with ulcerative colitis,
you can close
after
your stop. You can stop sharing your screen, so it'll become easier.
okay.
Yeah,
So, in patients with ulcerative colitis, after 8 years of their onset of the disease, we should start with colonoscopy.
that is the protocol, and the risk is very high. And at the same time, with family history, it becomes even higher. So you need to be a little more alerted to the cause. And the screening is not fecal occult blood, it is colonoscopy in these patients. And some people say that left side is more common than the right, although your patient has the right-sided one.
Right.
So we should not be confining. And in colonoscopy, what we'll do, we'll come to that. Any other question from anybody in the chat box? If you could put it, that will help. There are two questions. Shall we incorporate history of IBD in chief complaint? Actually, not in chief complaint, but you can give a reference of it, but you can put it uh, in the entire history of present illness. How will he differentiate intraperitoneal? I mean, I think that's a very Sumit. Intraperitoneal, how? Okay, Tanushri, can you answer that? Although it's an undergraduate question, but we'll cover it. How will you
Uh,
differentiate intraperitoneal from retroperitoneal swelling?
Sir, in the intraperitoneal lumps on head raise test or leg raise test goes inside, it becomes less prominent, and an extraperitoneal or a retroperitoneal lump stays the same, or extraperitoneal lump can also become more prominent.
I don't think that's a correct answer. I'm sorry. So they were right in asking. That's a difference between an abdominal and a parietal lump, what you're referring.
Okay.
So I'll repeat it for the benefit of everyone. These terms are used very casually. So I'm glad Sumit asked this question, whether it's for himself or for everyone. If you have an abdominal lump, it can be either in the wall of the abdomen or it can be inside the abdomen. Now, inside can be in the peritoneal cavity or behind the peritoneal cavity, correct? So let's not confuse um, if you are looking at the intra abdominal lump versus parietal. So for that, you need to make the muscles taut. If you make the abdominal wall muscles taut, if the lump becomes less prominent, it is definitely intra-abdominal. If it becomes more prominent, doesn't stay the same. It becomes more prominent, it's a parietal lump. I think that is easy, clear now.
Yes, sir.
Part two now. Suppose you have found out it's an intra-abdominal lump. So it's inside the abdomen now. Now, inside the abdomen, it could be within the peritoneal cavity or in behind it. If it is intraperitoneal lump, it will usually be mobile because all
With
intraperitoneal
respiration.
lumps will have a mesentery. It will move on respiration if it's in the upper part. Now, only those lumps that are attached to diaphragm or attached to those that are attached to diaphragm move on respiration. So liver is attached to diaphragm, moves on respiration. Gallbladder is attached to liver, so it moves on respiration. So if I hang Tanushri from gallbladder, she'll also move on respiration.
Mm.
So that doesn't mean inherently you are moving on respiration. It is because you are attached to something that is moving on respiration. Correct? Clear? Spleen moves on respiration frantically. That's why splenic artery is spring shape because it has to accommodate. Moves very well on respiration. Spleen, I'm talking. Now, anything that gets attached to spleen moves on respiration. So you may have a cyst arising, which can be going backwards also. Please understand that. So it moves on respiration. It's usually relatively mobile. And also, it is mobile side to side. Why is it mobile? Because peritoneal cavity, everything is mobile. Now, both these characteristics are absent in retroperitoneal lumps. They are neither moving on respiration nor are they mobile. They're usually relatively fixed in position and they tend to be restricted in their mobility. So that's the difference between. Is that clear? Parietal,
Yes, sir.
intra-abdominal is intraperitoneal, retroperitoneal, and there is No reason to get confused further on this. Now, let's not waste time there. We will have some other questions taken. Nimesh, you can keep putting all those who want to. I think this is a question. Can you please enlighten us about management of abdominal cocks non-responsive to AKT? This will take up later on after we have discussed the case. Now, let's proceed. What are you going to do?
Sir, first I would like
So
to.
it's a 73-year lady with a case of ulcerative inflammatory bowel disease on treatment, operated case of carcinoma of breast. I'm putting all in perspective now. Having received, uh, treatment for that for more than 8 years, now is presented with a right-sided colonic growth, according to you. Now, why is it colon? Why is it not liver?
Sir, because one of the chief complaints is melena, and that is majorly why I'm thinking more towards colon than liver. And she doesn't have any jaundice. Um, and she has a history of ulcerative colitis, which makes colonic malignancy more likely.
Okay. And why is it, bowel in anything else that you're talking about?
Sir, it's not kidney in that location because it is non-palatable.
Hmm.
So therefore it is bowel, and it is not liver for the reasons I've told already. The other organ is gallbladder. Again, gallbladder malignancies would have
Why is it not
jaundice.
liver? I couldn't understand clearly. That's why I'm asking again.
Sir, one of the main chief complaints was melena. So liver malignancies will not have melena as such in the primary complaint. She did not have any jaundice,
No,
and
but there could be an incident where there is a primary in the bowel and metastasis to the liver. So why is it not a metastasis to the liver? I'm not talking about primary in the liver. Primary would have produced melena. It's common. And metastasis to the liver is a possibility. So you will say you'd like to entertain that.
yes, sir.
That's a possibility. You would not say for sure that this is not this, this is this. Any other reason? What came first? She's got bowel complaints. And she's a case of ulcerative colitis. She's got history of melena. More likelihood, it's more probable that that it is a bowel lump rather than a liver lump. That's what you're saying. Now, the fact that it is continuous with liver dullness doesn't rule out bowel. Somebody asked that question. That has got nothing to do with bowel. It could be the hepatic flexure, which is continuous with the liver. That is where it can get confused. Therefore, when you don't get above the swelling, it becomes relevant. So let's see how do you proceed now. Let's complete the case, then we'll discuss the questions also.
Sir, first I would like to confirm my clinical findings and also support my diagnosis, and then investigate the patient and then treat the patient. So,
Mhm.
for confirmation, as an extension to my routine clinical examination, I would do an ultrasound, whole abdomen, and pelvis. So, in the ultrasound, first I would like to find out what is the organ of concern, and if there is a lump, then what is the location of the lump, what is the size of the lump, is there any what is the status of the lymph nodes, if this lump is actually getting attached to other organs as well. And I would also like to see if there is any presence of ascites, what is the condition of other abdominal lumps as well, if there is any other metachronous carcinomas or metachronous lumps that is present in the ultrasound. So that would be my first step.
Keep going. I'm not stopping.
Okay. So after this, if this supports my clinical finding, then I would like to go for CT abdomen and thorax. And meanwhile, I would also go for blood investigations because she's anemic. I need to know her nutritional status as well. I would also do tumor markers at the same time. And most importantly, I would go for colonoscopy and biopsy of the lump. And that biopsy, I would also send for immunohistochemistry of the MSI compatible.
If your ultrasound shows it to be colonic, lump, colonic mass. Actually, this wouldn't be a lump now. Would you still be going for CT first, or you would like to establish your diagnosis? You're not yet established. You would like to do colonoscopy
First
naturally.
colonoscopy.
So these orders don't bother me, but some people do ask with a lot of keenness. So if you're going for colonoscopy, what all you're looking for?
So for
In this
colonoscopy,
case, in this case,
okay. So I would be looking for firstly the lump. What is the exact location of the lump in the entire colon?
no, the lump is
And
over. Lump is a clinical feature. No, we are
sorry,
looking for a disease now. No,
disease.
lesion.
Yes, sir. The lesion. Okay. The location of this lesion, if it's actively bleeding or not, I would take a biopsy from the lesion. Other than that, I would also look for if there are any other lesions in the entire colon, and the condition of the ulcerative colitis as well. And if there are any other diseases with this, as like diverticulitis or something like that, that would also I would be looking.
You already answered that. So if in the exam the examiner is silent, that doesn't necessarily mean you have to speak something or the other. Okay. So I was keeping quiet just to see how long you're going to go on talking about it. Because you repeated the same thing many times, which is fine. You see, in any colonoscopy, there are some fundamental things which you'll do all the time. There's no rocket science. You put in a scope, you would like to see the status of the colon. You would like to see the status of the whether first you'll find out whether it's possible to negotiate. Status of the colon would be seen. Any polyps, and this is an inflammatory
Hmm.
bowel disease, you'll see the extent of the disease, any strictures, any weak spots, because one major risk in doing colonoscopy in ulcerative colitis patient or IBD patients is perforation. You need to keep optimum pressure of the gas inside. Then you'll see the lesion. You'll take its biopsy, correct you are, and you can even add, some people say, for an early disease, you can do an endoscopic ultrasound for the nodes, etc. But I don't think that is what you are looking at this point. You're basically trying to get a diagnosis first. Am I right? So get a biopsy, look for synchronous lesions. So that's a more smart way to answer. Look for the status or the condition of the IBD. Look for the other features which could be making it possible for you to take a call, because in this case we'll come to the treatment. The approach is totally different. Am I right? And
Yes, sir.
you are right about doing the contrast enhanced CT scan after that. But be careful when doing a colonoscopy. This has to be done by an expert, because it can cause perforation of the bowel, especially in a long-standing treatment. This can be a very weak bowel that can give way anytime. All right, so you've done that, and you've done CT for staging. How do you stage colonic cancer?
The two main stagings that we use is one is TNM staging based on AJCC's 8th edition, and the other one is Duke's staging. So based on TNM, because this this is actually if based on the CT, we'll see if it is in the mucosa, if it is in the muscular
Let's talk
layer,
about the
if it's
AJCC 8th edition staging, but that is more useful.
okay. So T is first is in situ, which is only in the lamina propria layer. Then T1 is mucosa. T2 is involving the muscularis propria. T3 if it is in the pericolorectal tissue. And T4 can be A or B based on peritoneum or organ involvement. Talking about the nodal status, N1 is either one lymph node is involved, and two is 2 to 3 lymph nodes, and 1B is 2 to 3 lymph nodes, and uh, and one is one lymph node, and two A and B. So that is 2 to 3 lymph nodes or involving the mesentery, and then there is 4 to 6 lymph nodes or 7 or more than 7 lymph nodes. And in metastasis, M0 when there is no metastasis, 1A is if there is any single distant organ or lymph node involved, and M1B is if there are more than one organs or lymph nodes involved. and M1C is peritoneal metastasis.
Not bad at all, and don't worry about it. People read an answer that is worse. So try to remember as much as you can. Otherwise, don't worry. You can always refer to these classifications anytime. If you do that daily, you'll remember. And then you mentioned in the you want to look for MSI, you want to do MS. Why do you need to look for in biopsy? You need to look at the grade, you're right. You need to look at the type, you're right. And when you're saying type, what do you mean by that?
So I would like to first look about the cells, if it's an adenocarcinoma or a signet cell carcinoma. That way the prognosis will also vary.
Which one has a worse prognosis?
Signet cell has a worse prognosis.
What do you mean by a signet cell?
In a signet cell, basically the nucleus is on one side and the entire cytoplasm, it looks like a ring. That is why it's called as a
Why,
signet
why,
cell.
why does it look like a ring?
Uh, I can't recall.
If there's a lot of mucin, is my whiteboard visible?
Yes, sir, it's visible.
Yes, sir,
Oh,
visible, sir.
it's a miracle. So I'm so bad at it, so that's why I was wondering. Now it looks something like this. What do I do with this? I am wondering. When this is a who is this person? What do I do about it? Again, I think everybody's writing. I messed up somewhere. Oh yeah. Shagun, I'm not able to write in this, so maybe I'll cancel it. Try again. Do I go for the new whiteboard or existing
So
whiteboards?
let's try the new whiteboard.
Okay. Then it comes communicate with comments. 15 people. What do you do now?
So just try writing something, sir.
Okay.
Yes, sir.
It's not writing. Some stars are coming. I don't know what is it.
So you could use the other one, the highlighter or something like that.
I don't think it is working, so I'll explain that way only. Now, when the cell has, a lot of mucin in it, the nucleus is pushed to the side. And when the nucleus is pushed to the side, it looks like a signet cell. So lots of mucin is not a good news for the cancer. It's a bad one. That would mean it's a bad cancer. You get my point?
Yes, sir.
So this is in the whole idea of the signet cell thing. And signet cell cancers do poorly. They don't have a very good, response to chemotherapy. They have a poorer prognosis in terms of chemotherapeutic response and in general everything. Now, coming to the uh, next question. So you've done the what do you call as the biopsy, and you got the grade, type, and what is this MSI that you mentioned? Why do you need an MSI?
So particularly in patients with HNPCC or Lynch syndrome, this is important. In the immunohistochemistry, MSI means microsatellite instability. So because of mismatch repair, these microsatellites that are already present in our DNA, they are not being removed, and which causes the mutation and hence the development of cancers in these patients.
So how is it relevant in therapy? Now, when we are planning immunotherapy or when you're planning something specific to a particular cancer, they become important, and it's necessary to get that report. Now, you want to do CT scan, you want to do every other investigation. Would you like to do an FNA FNA from the workhouse note before you do any of those investigations?
Yes, sir. I would like to do the FNA of the workhouse note because that would drastically change the TNM staging and that would become
So when
M1A.
you're saying it, don't forget that you described in your own findings there's a workhouse node being palpable. So you would need to exclude if it is a metastatic disease. If it is an M1 disease, it's a distant metastasis, which it will qualify as M1C again, and you will not be able to do surgery up front. Although surgery is the best palliation in colorectal cancers, regardless. But we need to qualify that. So we need to do that before we really get into doing all sorts of difficult investigations, expensive ones. Any role of PET scan
Sir, instead of CT, abdomen, and thorax, we can also do a PET scan. This would take
or a
care of
PET CT? PET
PET
CT
CT.
would take care of CT as well as the PET, and you'll have the biological activity as well as, sometimes, unfortunately, the tumors may not be proliferating that well, and they can be a false negative PET, which is again another issue that you need to look at. So you should stick to your algorithm of doing the ultrasound to know the organ of origin, so to confirm the diagnosis, then to stage the disease, and then to treat the patient. Now, you've done the needful, you've done the ultrasound. It's a disease of the hepatic flexure. We have 10-15 minutes to cover that. And there are no liver metastases. And it's in the background of inflammatory bowel disease. And FNA from the Werkhoff's node is non-specific. Repeat FNA rules out malignancy, which is what was done in this case. How do you proceed?
Sir, as you said in colon carcinoma, surgery has to be upfront and then followed by other medications. So I would go for surgery first. And in this patient, because there is also already a history of ulcerative colitis and she has a carcinoma, I would go for a total colectomy, be it abdominal or laparoscopic, based on the expertise available. And based on the condition of the rectum, I would decide for an ileal pouch anal anastomosis or a ileorectal anastomosis.
Now, you answered many things in one, which is very nice. So, how do you take that decision? How much of colon should go? She's
Uh,
73 years on treatment for so long. She's a post breast cancer. She's a breast cancer survivor. She's elderly, and ECOG is not great. So, how would you decide on the extent of colon to be removed? Suppose I do only right hemicolectomy or extended right hemicolectomy, which is what we do for cancers of the right side. In this case, it's hepatic flexure, so we do extended right. So, how would it be less?
so because once if a patient has a carcinoma, then the other patient, the metachronous carcinoma risk is very high in these patients already in a background of ulcerative colitis. Hence, I would go because she's already so old, she would not be able to tolerate another drastic surgery later
All
on.
right, that's the more important point. It's the risk of second surgery, something similar to obscure GI hemorrhage, or when you don't find any cause for bleeding. People used to do right hemicolectomy, which was blind earlier. Now it is not recommended because if they still bleed, you can't operate. So the only chance she gives you. And you can do subtotal colectomy, or you can do total colectomy with ileorectal anastomosis or ileal pouch, which is usually the J pouch that most people prefer, not the W. Now, how about this rectum? What is the risk of this rectum becoming? And you mentioned that in a very subtle way that if I can exclude any possibility of a risk in the rectum that is left behind. So, how do you exclude that?
So with the help of colonoscopy only, we are going to first see the condition of the rectum. If the rectum is normal,
That
there are
is
no
why when you are
polyps.
doing colonoscopy, it was important to know for sure that you are able to whether you are able to preserve how much. And in a lot of cases, you can do less than what you normally do, and the risk of their developing cancer on the other side or the remaining, as they say, the soil and seed theory. This soil is still fertile, and we know there is a risk. You are absolutely correct. So, first line, your answer should be it's a multimodality treatment where we would like to involve a good tumor board, multimodality team meeting, multidisciplinary team meeting where we would like to involve the gastroenterologist as much as we would like to involve a medical oncologist and geneticists, and everybody is involved in this so that we are able to take one collective call and we don't forget the morbidity that the patient is willing to tolerate. So when taking this decision, everything comes into play. You can't make the treatment worse than the disease. So it's not that you know the treatment for a particular disease in a particular group of patients that you'll use the same for all. In this patient, How would you single it out? And how would you plan? What would you do in this case?
Sir, I would go for a total abdominal colectomy and an ileorectal anastomosis.
Now, when you do an ileorectal anastomosis in these patients who have been in some kind of a treatment for an inflammatory bowel disease, what are the risks?
Sir, actually, because if there is a history of ulcerative colitis or inflammatory bowel disease, the risk of pouchitis is very high. So I would like to go for an ileorectal anastomosis for that reason only.
No, that is understood. How about the risks and the anastomosis? That may give way. So I would have been,
I would also do a diversion
yeah. So
ileostomy.
if you don't mention that, it is incomplete because you need to divert doing a diversion ileostomy is necessary to make sure that your anastomosis doesn't fail. And again, for the same reason, you can't go second time in these patients. So they have a very high risk second surgery for the same reason you did. Let's call it colectomy with ileorectal anastomosis. And pouchitis is a risk. I agree with you. And how do you make sure that the small bowel doesn't have the disease? Because sometimes inflammatory bowel disease extension to the small bowel as well.
Um, Sir, CT is a good modality, or else we can also do a CT enterography or a capsule endoscopy later on.
And you mentioned about the tumor markers. So, which one is that you? CA is one that you talk about. Any
C.
other?
So CA is more important. Otherwise, CA 99 is also one of the tumor markers.
Now, what is the problem with CA? CA 99, of course, boys, that is, of course, very, very subjective and very non-specific. But let's take the one that you do usually.
So CA is actually non-specific and in necrotic
Can you
areas
name
of the
some benign conditions where it may rise?
sir, I can't recall.
Where is it? I mean, it's got to do with liver.
Liver, yes, sir.
So now I've given you a hint. So what are the benign conditions that can? So cirrhosis of liver, alcoholics. They may have. I mean, and sometimes you may find CA is dropping, but the patient is dying. When the liver is started with metastasis, there's no CA produced. So
Mm.
see, when you're looking at a tumor marker, also think about the source. So CA is a very, very non-specific tumor marker, but useful for following up. For prognostication, it's useful. So I agree. Smoking also produces rise in CA, you know that. So there's so many non-specific reasons. Some gynecological conditions, hereditary form mole and all that, those, and there are lots of conditions. So non-specific, but for a patient where you know the disease and you're treating for that, it becomes relevant and it becomes specific in that case. Perfect. So how do you go about leading the team meeting? Suppose you were the one, you're the surgeon leading the team meeting. How do you get people into understanding what you're saying? First is the
Um,
patient's attendants, relatives. They need to be counseled that extensive exhaustive surgery may not be very good for her. We would like to do resection, and that's a bare minimum. And you cannot leave the cancer there. Then the next worry is the remaining part of the colon, if that is going to, or rectum, that can develop recurrence of colitis, that's the inflammatory bowel disease, but it's not as threatening as the cancer that is happening. Now you've taken it away, so patient is already on treatment for the inflammatory bowel disease. Now the treatment is for that limited part of the bowel, which is so the risk is reduced. What is the problem with total proctocolectomy and ileostomy?
so then it would be an end ileostomy. The continence obviously goes away. So it's going to be a permanent ileostomy for the patient.
So you need to counsel the patient. If the patient is willing, this would ensure 100% freedom from both the problems. But then that's a morbid surgery, not in terms of surgery, but morbid in terms of the patient will be having a permanent ileostomy, and it's obviously incontinent. Patient can actually be having an issue with that quality of life. There's one question that is coming, which now I'll take a few before I move to the adjuvant treatment because the surgery is being discussed. Hepatic flexure growth is invading into liver. What would you do? which happened in this case. That's why I'm asking. There's a question that somebody has asked which is very relevant. We would like to excise, but we'll do a non-anatomical resection. Don't take the whole segment out. Get a clear margin, get a frozen done. And a part of the liver was removed along with the growth to get an R0 dissection. Otherwise, a positive margin is not good news. And we get a frozen section done for this to make sure that we don't need to remove a lot of liver. But yes, liver can be removed, but we call it non-anatomical resection. I hope, Asif, you understood. Those who got asking the question, if the question is answered, they can mention that they got the answer. Now, you've done the surgery. How do you prepare this patient for surgery? We are proceeding to close.
So
Meanwhile, people can
nutritionally,
ask
first
their questions.
I will try to build the patient nutritionally as soon as possible, and I would do the pre-anesthetic checkup, and whatever the anesthetist say, I have to comply to that. I have to also give peg leg preparation so that the entire bowel has been cleansed, and then I would take the patient for surgery.
No, you didn't add to what, I mean, that is okay. You'll have to do what the anesthetist tells you, regardless of whether you like it or you don't. Anything specific?
Um, so that's all I can recall of.
How do you prepare the patient for surgery?
So bowel preparation.
Okay, what we understand by bowel preparation? Has it been shown to improve the outcome?
No, sir. It has not been able to. It has not shown to improve the outcomes.
So what do you do? Antibiotics.
That is also not shown to improve the outcomes. So
Okay. I don't know. I was again trying to use the board, but something starts happening. I must have. Sorry, I'm back to square one. Now, usual preparation, arranging adequate blood, preparing the
hmm.
patient mentally. Um, excuse me. She's a diabetic.
Yes, sir. So
So we need to take care of that. All comorbidities, high risk factors that you need to look into. Antibiotic prophylaxis is yes, but we don't. There's no great advantage of bowel preparation. In any case, it's called going to be resected, and we are going to do the anastomosis depending upon the. We must have a consent for permanent ileostomy and diversion. In any case, we do, and we would also convince the patient that it can become a two-stage surgery. Take consent for that. That's very, very important. And we go ahead and do if you're doing a laparoscopic approach, it starts on the right side and go to the left, and usually right and left, and then we come to the center and we look for the pedicles, take out adequate number of lymph nodes. the if you think it's too cumbersome, we can do open surgery, which is slightly higher morbidity. But even here, we need to retrieve the specimen through an incision, but by and large, manageable. And what do you do for how much of the small gut should be removed in the hemicolectomy or total colectomy?
10 to 15 centimeters.
Why?
So because some of the lesion can also be there, and for the anastomosis, sir, we need
So
a
suppose you're
removed.
doing a right hemicolectomy for tuberculosis. So what will you do? Right hemicolectomy, again, you'll take 10 centimeter of the terminal ileum. You know why? Because the ileocolic will branch off like this, and the space between the two is some bit of a window which is less vascularized, so that this terminal bowel is not very vascularized, closer to ICJ, so about 8 to 10 centimeter, and that is governed more by the trunk of the ileocolic artery, and you make sure that you have a supply to the part of the bowel, small bowel that you're leaving behind, right? And so therefore 8 to 10 centimeter. We don't count the centimeters, we look at the blood supply. So look for that arcade which is supplying. Ileocolic divides into the one that goes to cecum and the other one that comes
Helium,
to the ileum. And then ileocolic gives off a very famous artery.
appendicular artery.
Yeah, for very famous among the residents, that's what I'm saying.
Mm.
So so it goes towards the cecum and gives off an appendicular artery, we take care of it. and therefore this bowel is not going to be good for us, so we'll remove it. That's the reason. And there's nothing like ileo sending anastomosis in any case. Ileo transfers also, we do it uh, in a classical right hemicolectomy based on the vessel. Don't count the centimeters. In similarly, when you're doing jejunostomy, don't count the centimeters, count the loops and the blood supply. And you do the ileorectal, and this is what was done in this case. Ileorectal, we did no pouch. And how do you follow up these patients?
So they have to undergo routine colonoscopy.
We have to
Uh,
undergo, patient has to undergo, no?
Patient has to undergo
Right.
routine colonoscopy every 6 monthly for 2 years, and then followed by yearly. And they also have to undergo
And they have to
CT.
continue with their treatment. She has got a remaining part of the rectum. So her treatment for the ASA should continue. She should be again under the consultation of a gastroenterologist and endocrine person for the diabetes, and for the cancer we can follow up in the oncology. And again, there's a you discuss the case in the tumor board regarding the follow up and screening. For what do you do for screening? You can't put a scope into a pouch too far, right? Into a remaining part. Like you the vault there, you have a vault here also now, but you anastomosed. So therefore, you need to see that the you know,
Anastomosis.
yeah. And this patient had a little few clots coming in the rectum, but the stoma was functioning. I'm giving you a brief background of this case. So these clots coming would indicate what?
Um, so the clots could actually be a sign of anastomotic leak, but then if the diversion ileostomy is in place, then it is nothing to worry about. The anastomosis most likely heals on itself. We just have to be sure if there's no collection in the abdomen. That's it. And there's no infection.
Nicely answered. We need since that is the reason that justifies your diversion ileostomy for this reason. If you're not diverted, you would be wondering. It's important to divert for this reason because there could be an anastomotic ooze, as they call it, not bleeding, which can happen. Any question? And what antibiotic, what chemotherapy this patient should get? I forgot. Yes, last part.
So chemotherapy, most likely after discussing with the tumor board, so we give folfirinox.
So what are the components of Volferi or Volfox?
So 5 fluorouracil and oronekitan and sorry, I can't remember the third one.
When you're putting the patient on chemotherapy, what do you take into consideration? Performance status again. She's 73, right? She's to be fit enough to be able to take that chemotherapy effectively. And you have to take a call if her performance status is good enough. And naturally, the chemotherapy otherwise remains just the same. It's not different, Folfox or Folfiri, depending upon the protocol that a unit follows. But Folfiri is what we follow. So we discussed it in the MDT and involve the medical oncologist and others, and we can actually get on with it. And there's no other treatment that is recommended, except in cases any scope for KRAS gene mutation assessment in these patients.
Yes, sir. If KRAS or BRAF are positive, that means that they are not Lynch syndrome. Basically, they're separate. So that is important. We have other immunotherapy which are targeted to BRAF and KRAS as well, so we can give those immunotherapy.
They usually in the metastatic setting, but otherwise um, um, not really indicated. Sir, the role of neoadjuvant chemo. Somebody's asked a very good question. The role of neoadjuvant chemo, Tanushri.
So in colorectal surgeries, it's better to first operate and remove the source of
So,
cancer,
what are
and
the
then.
indications? Suppose you have to.
So if it's an obstructing carcinoma, then we can just do a diversion ileostomy and go for neoadjuvant chemotherapy till when we can do the surgery.
Well, when you say obstruction or perforation, the answer is surgery. Mass palliation is surgery, you're right. But if it is borderline resectable disease, then we can put the patient on neoadjuvant chemotherapy. In a metastatic setting, it's not called neoadjuvant, then it's called primary chemotherapy because neoadjuvant is for some when you have to follow it up with some kind of a definitive treatment, which is surgery here. So there is a role of neoadjuvant chemotherapy in non-resectable tumors. Otherwise, surgery is the best approach up front. There is also a concept which like very much like in breast, where they feel that if you keep the microenvironment of the tumor alive, then immunotherapies work better. That's when you're planning immunotherapy in triple negative breast cancer in younger patients. If you do surgery first, then it may not be useful because the microenvironment is destroyed. And immunotherapy is nothing but using your immunity against the tumor, or making your cells like CAR T cell concept, where you wake up your T cells to know that this is foreign body and you kill it. So to stimulate that, you need the tumor. So interestingly, when you if you have to use a you know the immunotherapy, then this environment microenvironment is kept intact. Post surgery, it has no role. So only the metastatic setting where you can actually find it useful. Right? Any questions, Shagun? Dr. Shagun and any other faculty that would like to ask question? Any student, if there is any question, we are going to conclude.
Um, so, sir, is the I wanted to ask Tanushree.
Hello?
Hello.
Yes, sir.
Yes.
I can hear
Hi,
you.
Tanushree, is there any role of upper GI endoscopy in this patient?
Yes, sir, definitely. Because many a times all of these inflammatory bowel disease can also involve duodenum also, and so it's very important, and gas stomach also. So it's very important to actually have a look at them. Also, in like not particularly to this case, but then if there are other polyps in the patient, then the polyps can also be present up, and in those patients, duodenal polyp bleeding is the one of the most common causes of death in these patients. So upper GI endoscopy is very important, particularly when she's also having melena. We have to look for any upper GI bleed also if it's present or not.
So, thank you.
Yeah, and actually that was important, and you need to cater to it. So, sir, what is the role of what lesion is seen having deposits near middle colic vessels? And any lesion can be seen with deposits near the middle colic vessels, depending upon whether the nodes are involved or not. So I'm not getting what if, okay, the lesion is seen with having deposits near middle colic vessels. So what do? Go further down. Middle colic is involved, and you go further down,
Extended right.
and then you can do extended right in those cases. And but the important thing is if it is involving right, the middle colic is a branch of it's a artery coming from superior mesenteric artery. So please don't suggest that we're going to ligate superior mesenteric artery. So we are going to clear off and flush with the superior mesenteric artery. And if preoperatively you can make out there's a case for putting the patient on neoadjuvant. Node clearance is very, very important in these patients. I hope that is clear. Any other question from any student is welcome before we close. So, if there's none, I think we can close it. Tanushri, do you have a question? Anything that you would like to know?
Oh, no, sir. Almost.
But you made an excellent presentation, and there was excellent discussion. So we're not having a second case because we covered up with one, and we'll try to have one case at a time. And maybe next Sunday we'll try to do ward rounds or something different in between so that all exams get covered adequately. Right? So thank you all for joining. I hope you enjoyed it as much as we enjoyed getting it to you. Now this becomes a regular feature, and do join for your own sake. And we look forward to catching you up next week or next Sunday. Right? Right, Tanushree, thank you very much.
Thank you so much, sir. Thank you.
Thank you, sir.